of this respiratory session, and I must thank Dr. Syamal Sarkar who has joined at this particular moment. So I think it should continue now today, and I will hand over to Dr. D.P. Singh to continue the session. Thank you, D.P.
Thank you, sir. We are privileged to have Dr. Syamal Sarkar, a renowned pulmonologist from Ranchi. And he is going to lead our master teacher class today on none other than the topic which is very important, very serious, underdiagnosed, underrespected, and undertreated. So at that topic, Dr. Sarkar has done his MD and DTCD from PGMER, SSKM Hospital, Kolkata. And he's the director and running a clinic, advanced chest clinic and sleep apnea medicine center in Ranchi. Also, Orchid Medical Center, he is the senior pulmonologist. He is holding the post of Indian Chest Society chairman in Jharkhand, and he has delivered a lot of lectures on pulmonology in the state journal and national conferences. Let us join hands to welcome Dr. Syamal Sarkar to this occasion to give his expertise, give his insights and understanding of a very important topic, that is pulmonary thromboembolism, and let us enrich ourselves by his deliberation. Over to Dr. Syamal Sarkar. If you have any difficulty, Anand, our technical support will help you.
Yes, I have to just screen share.
Yeah.
It cannot be done from here. स्क्रीन शेयर नहीं हो रहा, स्क्रीन शेयर करने पड़ता ना उसमें। स्क्रीन शेयर तो ऑप्शन इधर नीचे है, इसको हटाया, ये जो स्क्रीन शेयर
If you have any difficulty, you can send the slide to Mr. Anand. Yeah. Anand, would you help him?
Yes, sir.
Getting some problem. Anand can help him.
आनंद
जी सर, सर आप
इस पे
स्लाइड भेज दीजिए। सर
हमारे
स्लाइड भेज दीजिए।
मेरे डेस्कटॉप में है, उसको कैसे शेयर करेंगे?
सर जूम में सर एक शेयर ऑप्शन होगा, ग्रीन कलर का बटन होगा, ऊपर में एरो होगा सर।
अच्छा, ये कलर का बटन,
chat react हो
मेल कर देते।
सर यदि आप ये हो रहा सर ये स्लाइड सर व्हाट्सएप चाहे मेल कर दीजिए सर प्लीज।
I have sent you the mobile number of Mr. Anand. Sir, Dr. Shyam, you can try, but send it, the slides to him. Yes, slide has come and you can make it on the slideshow mode. Yeah, that's good. Yeah. You can start. Dr. Shamal.
Hello.
You
Sir,
can
can you hear me, sir?
Yeah, very well.
Okay. Okay. So at the very beginning, I would like to thank Dr. Jyotirmoy Pal, President API, Dr. Kamlesh Tiwari sir, Dean ICP, Dr. Girish Mathur, Dean-elect ICP, and Dr. Agam Bhora, one of my best friend from Mumbai, who is honorary General Secretary API, and Dr. DP Singh, my close friend from Bhagalpur, as a course director. And I thank especially Dr. DP Singh for inviting me and for conducting so a beautiful, hectic course in the API platform. So my topic today for discussion is the diagnosis and management of pulmonary embolism. And it is then naturally, as said by Dr. DP Singh, that it is very important medical problem, and often we miss the diagnosis, and timely diagnosis and proper management is very crucial to save the life of the patients. Now, venous thromboembolism is actually considered as a spectrum. We can't differentiate the DVT and pulmonary embolism because they are very close to each other, and they are many times they are linked together. And pulmonary embolism, as defined as the obstruction of pulmonary artery or its branches by a blood-borne material, which can be a thrombus, tumor material, air, or fat, and that originates elsewhere from the body. Elsewhere in the body. As you can see in this figure, DVT is the most common source of pulmonary embolism, and a thrombus dislodged here, and the emboli coming from the lower limb veins across the inferior vena cava, enters the right side of the heart, right atrium, then right ventricle. Then it passes into the pulmonary circulations in the main branches. And depending upon the size of the emboli, they either lodge in the subsegmental or peripheral branch of the pulmonary artery, or if it is large enough, it can occlude the main pulmonary artery. In case of small thrombi, usually the lower lobes affected because of the dependent blood supply at the lower lobes. Most commonly, it is found in the lower lobes. Now, why it is important? Because the sign and symptoms of the presentation of the pulmonary embolism is very non-specific. And that's why, despite the recent advances in the diagnostic capabilities, delay in the pulmonary embolism diagnosis is very common and represent an important issue. So the key to the diagnosis of acute pulmonary emboli is high clinical suspicion. So today we're going to discuss how common is acute pulmonary embolism. When does one suspect an acute pulmonary embolism? How does one confirm a diagnosis of acute pulmonary embolism? And how does one risk stratify acute pulmonary embolism? And based on the risk stratification, how does one manage acute pulmonary embolism? So as the other streams of the medicines, there are lots of guidelines in pulmonary embolism, as you can see in the screen here. So American and European, lots of guidelines, but the latest guideline is European Society of Cardiology, which is definitely and a very good guideline with evidence-based. And most of this my talk will be included from this 2019 European Society of Cardiology guideline for the diagnosis management of acute pulmonary embolism. Now, how common is acute pulmonary embolism? The annual incidence rate, according to statistics, is 50 to 160 per lakh in the USA. It is the third most frequent major cardiovascular disease globally, behind myocardial infarction and stroke. Pulmonary embolism is also the third most common cause of death in hospitalized patients. Now, clinically relevant pulmonary embolism is much less common than pathological pulmonary embolism, as autopsy data showed overestimate both incidence and mortality rates. Less than 40 years of age are definitely at lower risk, but as the age increases more than 40 and doubling of the risk factors, risk is added with each decade. Acute pulmonary embolism is confirmed in only 6 to 9% of those investigated for pulmonary embolism in emergency department. And among inpatients, however, the incidence is much higher, which tells us that the patients we are treating in a hospital in different departments, surgery, neurosurgery, cardiology, intensive care units, these are the patients who are at increased risk of development of pulmonary embolisms, and we have to cautious about that. Now, this slide shows the trends of the annual incidence rate and the fatality rate in different parts of the world. As you can see, the incidence rate of pulmonary embolism is increasing in all the countries. But fortunately, the case fatality rates are decreasing. This might be because of the increased awareness among the physicians and availability of the diagnostic modalities. That's why there is increasing rates of diagnosis. And with the help of guidelines and proper treatment, timely treatments, there is decrease in the case fatality rates. Now, how dangerous is pulmonary embolism? The patient, 60 to 80% of the patients with pulmonary embolism usually has associated DVT, but most of the cases, more than half of the cases, they are asymptomatic, and that makes the diagnosis difficult. Pulmonary embolism usually develops 3 to 7 days after DVT. Among them, 5 to 10% have shock or persistent hypotension, and the 30-day mortality rate of patients who develop shock is up to 25%. And those who developed cardiac arrest, the mortality rate is as high as 65%. Most deaths in patients presenting with shock occurs within the first hour of after presentation, and most of the time patients don't get any medical advice or medical facilities, and they succumb to that. Most fatalities occur in untreated patients. But if you treat the patients properly and timely, perfusion defect almost completely resolved in 75% of all patients who survive. It is estimated that nearly half of the pulmonary embolism occurs in hospital or healthcare related institute. That means it can be preventable. How it can be preventable? If we cautiously note our patients, if we identify the risk factors amongst our hospitalized patients and give proper measures or prophylactic measures in time, with the catastrophic results can be avoided in most of the cases. So how can we prevent this? By identifying the risk factors. So risk factors are basically divided in two parts: patient-related and setting-related. Patient-related risk factors are usually permanent. Most of the times are genetically mediated, like inherited causes of factor V laden mutation or deficiency of antithrombin 3, protein C, or deficiency of protein S, etc. And these are the risk factors which are unprovoked. And these patients at very risk of development of pulmonary DVT and pulmonary embolism, and that are unprovoked. They are very difficult to diagnose as well as very difficult to treat. The other cause risk factors are setting related. These are usually temporary. Temporary means either post-operative or post-trauma or hospitalized due to any other illness with long immobility. So these are the provoking factors. So setting-related factors are usually provoking factors. So there is an interaction between patient-related factor, which are permanent, and setting-related factor, which are usually temporary. And it is considered that patients with provoked risk factors, they develop pulmonary embolism and DVT within 6 weeks to 3 months before their diagnosis. And unprovoked case, these are not present. So the presence of permanent factors, what is the importance? Diagnosing the patients with permanent factor can affect the duration of anticoagulation and other measures taken for these patients. So risk factors usually they are described as the viscose triad. As the name says, triad means there are 3 primary factors that predispose to the blood clots inside the body. And these 3 important factors are endothelial injury, stasis, and blood hypercoagulability. Stasis can occur in hospitalized patient, at bed rest patient, in intensive care unit, long hour of travel, in pregnancy, as well as in congestive heart failure. Hypercoagulable state can develop in patients, in ladies, women with oral contraceptives, patients with cancer, in case of pregnancy and post-operative periods. An endothelial injury can occur in trauma to the blood vessels, trauma to the bones, post-surgical patient, as well as in central venous lines or IV drug abusers. In these cases, there is endothelial damage that predisposed to the development of venous thromboembolism. If any cause cannot be identified, it is often considered as the idiopathic. Again, what is the importance of assessing this risk factor? Because we can prevent the recurrence and consequently for the decision-making of the chronic anticoagulation cases. As the guideline says, that strong risk factor, moderate risk factor, and weak risk factor. We must remember the patients who are at strong risk for the development of DVT, particularly fracture of lower limbs, hip or knee replacement, major trauma, patients with spinal cord injury, patient hospitalized for heart failure or atrial fibrillation within the previous 3 months, and myocardial infarction within the previous 3 months, and previous history of VT, they are at increased risk of development of the VT and pulmonary embolism. At least this strong risk factor must be remembered by us. Now, what is the pathophysiology? If they develop pulmonary thromboembolism, what happens? In the initial stage, actually, there is hemodynamically stable period, but depending upon the size of the thrombi and the underlying cardiopulmonary status, the patient develops progression of the pathophysiological problem. So initial stage may be stable, but quickly they may develop to the hypotension and shock. And once the patient develops shock, and the mortality rate rises to 30%, and thereafter mortality rate steadily rises with the development of cardiac arrest and sudden death. So pulmonary embolism is a syndrome. At one side, patient may be asymptomatic, may be hemodynamically stable. On the other side, the patient can present with cardiac arrest and sudden death. So during the period of hemodynamical stability, if we can identify this patient and if we can take proper measure, so the lives can be saved in these patients before they develop serious problems. This slide also shows the same problem, the relationship between the pulmonary embolus size and the underlying cardiovascular function. As you can see in the red curve, when the patient has predisposing factors like cardiopulmonary problem, particularly if the patient has LV dysfunction, in that case, even a minor or small size of pulmonary emboli can result in high mortality. On the other hand, in the green curve, as you can see, if the patient has good LV function, so sufficiently large pulmonary thrombus is needed to increase the mortality. So the pathological consequences depends on the not only the embolus size, but also the underlying cardiac status of the patients. So what happens when the pulmonary embolism lodges in the pulmonary circulation? There is increase in the pulmonary vascular resistance because the anatomical obstruction with the release of thromboxane A2 and other neurochemicals and neurohumoral effect, there is increase in pulmonary vascular resistance. And with increase in pulmonary vascular resistance, the right ventricle has to push blood against the increased resistance of the pulmonary circulation that ultimately results in increase in pulmonary artery pressure. An increased pulmonary artery pressure develops in right ventricular dysfunction within few days. And when the patient develops right ventricular dysfunction, there is right ventricular dilatation, which results in the interventricular septum, pushes the interventricular septum towards the left ventricles. So results in interventricular synchronization. The left ventricular filling is reduced, and that ultimately results in decreased LV preload. And with decrease in the preload, the patient develops decrease in the output, decreased coronary perfusion, right ventricular as well as left ventricular ischemia. On the other hand, with the development of right ventricular dysfunction, there is also a decrease in right ventricular output. And with series of interaction, ultimately it results in left ventricular decrease in the preload and decrease in the output and hypotension. So this also same thing is here more or less. So with increasing RV afterload, after occlusion of the pulmonary circulation or with embolus, there is progressively increasing right ventricular afterload, resulting in RV dilatation, RV wall tension, RV oxygen increase in the RV oxygen demand, intrapulmonary AV shunting, which increases the hypoxemia, right ventricular ischemia and hypoxic injury, decrease in right ventricular contractility, decrease in right ventricular output, which ultimately result decrease in left ventricular output, decrease in cardiac output, hypotension, and a decrease in coronary perfusion and decrease in right ventricular oxygen delivery. So at one hand, there is increase in right ventricular oxygen demand. On the other hand, there is decrease in oxygen delivery that ultimately results in obstructive shock and death. So these are the pathophysiological background. Respiratory failure, usually the problem of respiratory failure is basically a circulatory failure that results in hypoxia because there is hemodynamic. So it is the results of hypoxia is the result of hemodynamic compromise, increase in the alveolar dead space, right to left shunting, ventilation perfusion mismatch, and low mixed venous oxygen level. The combination of all these factors results in hypoxia. So basically, it is not a primary pulmonary problem, a problem with circulatory problem that ultimately results in pulmonary symptoms and abnormalities. So usually how they present, the acute pulmonary embolism patient, most of the time, they present with dyspnea, with or without pleuritic pain or hemoptysis. In most of the cases, about 90% cases presents like this. They may have no right ventricular dysfunction or with right ventricular dysfunction. What is the difference? If the patient has no right ventricular dysfunction, the mortality rate is less. But if the patient has right ventricular dysfunction, as we described in the previous slide, the mortality rate doubles in 15 days and triples in the 1 year. Another good presentation is patient can present with acute syncope, hemodynamic instability, shock, and arrest in very serious condition. But fortunately, only 10% of these patients present with these serious conditions. Initially, it was told as the massive described as the massive, but it is a clinical misnomer. Nowadays, it's said that the major pulmonary embolism or pulmonary embolism with hemodynamical unstable, they have the very high mortality, about 7 times in comparison to the baseline. So whenever we come across such patients, we have to do some initial investigations. ECG, chest X-ray, arterial blood gas must be done, but they are not specific, non-specific, and they are not helping in confirmation or excluding the diagnosis. But they may provide an alternative diagnosis, and also they may influence the assessment of the clinical probability. These are the ECG changes. The most commonly found abnormality is sinus tachycardia of non-specific STT changes, though S1, Q3, T3 pattern of pulmonary embolism is described as the classic finding, which is also known as the McGinn-White sign, but it is found only in 10% of the patient. As you can see here, the S in lead 1, Q3, Q in lead 3, and T inversion in lead 3. So S1, Q3, T3, it is very importantly said to be as classic finding, but we don't believe on this. We don't depend on this because it is found only in the 10% cases. Other findings are atrial arrhythmia, particularly atrial fibrillation, right bundle branch block, inferior wall Q waves, and precordial T inversion, right ventricular T inversion, and STT changes. These changes are associated with poor prognosis. Chest X-ray usually abnormal, but non-specific. There can be pulmonary effusion, pulmonary artery enlargement, or pleural effusion, atelectasis, or infiltration. But chest X-ray may be normal in 24% of the cases. A number of signs are very attracting signs are described in pulmonary embolism as the Hampton sign, which is the radiological sign of pulmonary infarctions, which is a rounded or triangular opacity subpleural region with the apex towards the hilum and base towards the pleura. So this is called Hampton sign. Similarly, Westermarck sign is the area of polygemia in the lungs. And Klesner signs are the enlarged pulmonary artery. So these are characteristic, but not so commonly found in patients, all patients with pulmonary embolism. ABG, if we do an ABG, there is usually hypoxia, but 40% patient may be normal ABG. And the abnormality, if there is abnormality, usually hypoxia, hypocapnia, and respiratory alkalosis. So this study showed that the patient can present with dyspnea, pleuritic chest pain, cough, substernal chest pain, fever, hemoptysis, syncope, unilateral leg pain, or other signs of DVT like unilateral extremity swelling like that. But you can see the patient who are suspected to have pulmonary embolism and ultimately confirmed pulmonary embolism, and there was pulmonary embolism was not confirmed. So you can see the same symptoms more or less have equal frequency both in patients with confirmed pulmonary embolism as well as non-confirmed pulmonary embolism. They're like dyspnea in 50% and 51%, pleuritic chest pain 28-39%, cough 23%. What does it mean? That means we cannot depend upon these signs and symptoms for confirmation or diagnosing pulmonary embolism as an accurate measures, because it can be present both in patients who are confirmed and unconfirmed pulmonary embolism. There are a number of pitfalls also. 30% patients with confirmed pulmonary embolism do not have predisposing factor. 40% patients with confirmed pulmonary embolism do not have hypoxia. 40% patients with confirmed pulmonary embolism have sinus tachycardia on ECG rather than the classical ECG sign. 59% of the fatal pulmonary embolism were undiagnosed during their lifetimes. So there are a number of pitfalls. So what we can do here? So with the help of symptoms, signs, and the basic investigations, we may not be able to confirm the diagnosis of pulmonary embolism. So what is done? So it has been found that with the availability of CT, pulmonary CT angiography, and other diagnostic modalities, doctors are using these investigations in patients with symptoms and patients with hypoxia. So with the result that there is misuse of the diagnostic modalities, actually costly and also risky. CT scan, etc., are many times are done without any benefit or without any final conclusions. And these studies was shows that pulmonary embolism confirmation among patients undergoing diagnostic workup were as low as 5% in the recent North American diagnostic studies versus 50% prevalence reported back in the 1980. So to reduce the misuse of diagnostic workup, so ultimately what they take the measures that they have developed certain clinical pretest probability rules of or scoring systems. And Wells rule and Geneva rules are the two most important validated rules which are used for the pretest probability. What we do with this test, with these rules, say they involve certain characteristics, clinical features and symptoms of the patient. And with the help of this combination of the characteristics of the patient, they group the patient in three categories. Three group categories, that is low, intermediate, or high probability. So what is the probability of having pulmonary embolism or final diagnosis of pulmonary embolism with the help of this constellation of the features? And that helps in the pretest probability assessment for the different patients in the clinics or in the emergency room. So there are three group category grouping of the patient: low probability, intermediate probability, or high probability, or two group category, either pulmonary embolism likely or pulmonary embolism unlikely. So what we should do whenever we suspect a patient in the emergency department, we have to use the PARCUP steps. So PARCUP is the pulmonary embolism rule out criteria. So this is very beneficial for the emergency department doctors, because we have to remember these 5 or 6 criteria. And if these are present or absent, we can, if they are, we can exclude the patient for having the diagnosis or doing further activities. And these features are: if the patient has less than 50 years, they have low risk. If pulse rate less than 100, SaO2 more than 94, no unilateral leg swelling, no hemoptysis, no recent trauma or surgery, no prior DVT or pulmonary embolism, and no oral hormone use. So these are the 8 criteria. If they are very low in clinic, if the patient is in a low clinical suspicion and the patient fits all these 8 criteria, then the probability of pulmonary embolism is very low and no further testing is required. And that's why it is called rule out criteria, pulmonary embolism rule out criteria or PARCUP criteria. It is very useful. The other rule is the Wells scoring system. And they use these 9 or 8 parameters, and these were the original scoring system, but it was very tedious to remember scoring 3, 1.5 like that. And that's why they ultimately developed a simplified Wells scoring system, which is one score for each parameters. And they ultimately divide the patient in the low risk, intermediate, and risk, and high risk according to scoring systems. So Wells scales, and similarly there is Geneva scoring system, the original Geneva version and the revised version. So this is much more better, and you can keep it in our clinic or in the emergency room. This is the very good simplified Geneva score system for the assessment of the probability of pulmonary embolism. It has a 1 point for each of these factors. If the age is more than 65, previous DVT or pulmonary embolism, surgery or fracture within 1 month, active malignancy, unilateral lower limb pain, hemoptysis, pain on deep vein palpation of the lower limb, and unilateral edema, heart rate 75 to 94 have 1 point. And if the heart rate is more than 94, 1 additional point is given. So in this way, we can do a scoring system. If the score is 0 to low, 0 to 1, it is called low probability. 2 to 4, intermediate probability, and 5 or more, high probability. Similarly, if 0 to 2, it is pulmonary embolism is unlikely. and 3 or more is pulmonary likely. Now, what is this implementation of this scoring system? Actually, we can have the idea about the proportion of the patient with confirmed pulmonary embolism. Low probability category has a 10% probability of confirmed pulmonary embolism. Moderate probability category, intermediate category 30%, and high probability category is 65%. Similarly, if the patient is pulmonary embolism unlikely, so 12% probability, and pulmonary embolism likely, 30% probability of confirmed pulmonary embolism diagnosis. So this is the pre-test probability scoring system we have to adopt ourselves. We have to make a practice ourselves to have an assessment how the patients, we can advise the patient of the next step of the diagnostic systems. So D-dimer, we commonly use this. D-dimer is a fibrin degradation product. Positive predictive value is low, negative predictive value is very high. What does that mean? If the D-dimer is positive, it is not necessarily diagnosed the pulmonary embolism. Rather, it has a very high negative predictive value. So in a patient, when we suspect pulmonary embolism, according to their signs, symptoms, and other clinical presentation, D-dimer helps to rule out the patients, particularly in the low probability cases, but is not in high probability. There are different methods for the measurement of the D-dimer, but the ELISA method is the best. ELISA test have the high sensitivity, more than 95%. But it is very much important to know that the D-dimer can be increased in a number of conditions and can give a false positive result like cancer, sepsis, inflammation, pregnancy, elderly, hospitalized patient, etc. They can have high D-dimer falsely. So as an alternative to the fixed D-dimer cutoff, usually many a times we use the D-dimer 500. Less than 500 normal, more than 500 is abnormal, but this is not advised. Age-adjusted cutoff has to be taken into granted for the diagnosis of D-dimer. And age into 10 milligram per liter, particularly in patients more than 50 years, should be considered to consider the importance of the D-dimer report. Now, when we should use the D-dimer, actually, the guideline says the plasma D-dimer measurement is recommended in low and intermediate clinical probability or pulmonary embolism unlikely group of the patient. Why? That to reduce the need for unnecessary imaging, CT scanning, and negative result exclude pulmonary embolism safely in pulmonary embolism unlikely patients. But D-dimer measurement is not recommended in patients with high clinical probability, as a normal result does not exclude pulmonary embolism. In fact, negative D-dimer can miss up to 15% of the patient in high-risk group of the patient. So it is the modality of diagnostic modality which is used only in the low and intermediate probability, not in the high probability. CT pulmonary angiogram is nowadays considered to be the gold standard. It has also negative predictive value up to 89 to 96% in intermediate and low risk groups, and positive predictive value of more than 96 in intermediate and high risk groups. Segmental clot presence confirms the pulmonary embolism. CT venography of the lower limbs, when combined with CTPI, increase sensitivity further. It is most of the states in our cities, the now hospitals, the CT pulmonary embolism angiography is available. And the other advantage that CT angio can also give alternative diagnosis like pneumonia or other lung disease. We can also have an assessment for that. But the negative point that it contrast uses, so high radiation exposure. So what is their nutshell? When do CT underperform? So in low probability or intermediate probability, if the CT angiography gives a negative report, so we can rule out the possibility of pulmonary embolism because it is a low predictive value in low risk group of the patient. But if it is positive in case of high predictive probability of the patient, and we have a positive pulmonary diagnosis of this case, and we can straightway advise the patient for the further treatment. The problem arises if there is low negative results in high probability group or a positive result in the low probability group in CT scan. In that case, the conclusion is very difficult to take, and further other modalities of investigation should be done for confirmation of the diagnosis. Ventilation perfusion CT scan. Ventilation scan is technetium 99 used for the ventilation, and Xenon 133 is used for the ventilation scans. So this is well-validated test, safe, less allergic, less than 50% radiation exposure. A special group of the patient will benefit from it. Special group, that means patients with having a normal lung function, a normal lung in the chest X-ray, pregnant patient, patients with renal failure. So these are the patients who get benefit from this VQ scintigraphy. Results are grouped into normal, high probability, and non-diagnostic scan. Presence of 2 or more segmental perfusion defect with normal ventilation is diagnostic in 90% of the cases. As you can see, this is the normal perfusion test, VQ scintigraphy, and this is the abnormality, VQ. The ventilation and perfusion mismatch is the diagnostic criteria. But in India, limited, as it is not freely available, needs expertise to interpret, and availability of the isotope and other inferior to but is not available so freely as in CT angiography. And as such, it is also inferior to CT angiography. Echocardiography is very important modality for the useful in the pulmonary embolism patient. And it is also the diagnostic a tool which is very frequently used in all the hospital. Even in intensive care unit, there are portable echoes are available. So this is, we must learn about what are the echo features of the pulmonary embolism to help in the diagnosis in the bedside. So RV dilatation found in 25% of the cases. This is very important. So 25% patients only presents with RV dilation. So negative predictive value is only 40 to 50% due to other confounder. Not any investigation for low risk, how to have not shocked. So non-shocked patients, they have limited utility. So in a patient of pulmonary embolism suspected to have shock due to pulmonary embolism, and if echo shows normal RV function, it rules out pulmonary embolism. So actually shock in pulmonary embolism is due to RV dysfunction. And this RV dysfunction can be identified with bedside echo. So these are the features. So there is RV dilation. RV dilation in parasternal long axis view. In apical 4-chamber view, we can see there is RV dilation and RV-LV ratio more than 1. There is a science called McCollin science. That is, apex is spared, but the right ventricular free wall show hypokinesia, sparing the apex. So this feature is called McCollin science. There is straightening of the interventricular septum, and which can show a bowing towards the left ventricular side. As you can see here, so this is the enlarged right ventricle in comparison to the left, and apex is more or less spared, but free wall shows hypokinesia. And here you can see right ventricular dilation results in bowing of the interventricular septum towards the left ventricles. So these are the important findings here. This is called transient. Sometimes you can see thrombus in the right ventricle or right atrium or even pulmonary artery, but this is transient thrombus. Others is TAP-C, tricuspid annular systolic excursion less than 60 millimeter mercury, which also indicate right ventricular dysfunctions. And overall, these right ventricular dysfunctions in the echocardiography or right ventricular free wall contractility depressed against the apex, right to left shunt through the patent foramen oval, and presence of mobile right head thrombi, TAP-C less than 16. These are the important features, echocardiographic features with high short-term mortality. Comparison venography. So this is again a bedside modality of diagnostic modality, which is very useful in suspicion of pulmonary embolism and also DVT. In the majority of the cases, pulmonary embolism originates from DVT in the lower limb. And this compression ultrasonography has a sensitivity more than 90% and a specificity approximately 95% for the symptomatic DVT. More than 70% of pulmonary embolism patients have DVT. So whenever we suspect pulmonary embolism, look for the DVT, and we can find 70% cases the DVT. Proximal DVT in pulmonary embolism suspected patient is good enough to start anticoagulation and class 1 recommendation. Incomplete compressibility is a validated criteria for DVT diagnosis. While doing compression also, if the deep veins in the lower limb are compressible, that is normal, but it is incomplete compressible is a diagnostic sign of presence of deep venous thrombosis. Flow measurements are not so reliable, but the incomplete compressibility is a very important finding we have to look for. The probability of a positive proximal cause is suspected pulmonary embolism is higher in patients with symptomatic DVT. So acute pulmonary embolism patients actually can present in two syndromes: high risk patients with shock and non-high risk without shock. So when the patient presents with shock, they are called high risk patients, high risk of mortality. And if the patient has no shock, that is non-high risk. So basically, presence of shock indicates the significance of the clinical importance of the patient or seriousness of the patient, because ultimately it dictates the mortality rate of the patients. And how we can identify these shocks? The patients with either of these three clinical features indicates the hemodynamic instability of the patients. If the patient has cardiac arrest, needing cardiopulmonary resuscitation, or the patient has BP, systolic BP less than 90 mmHg, or vasopressure required to achieve more than 90 mm despite adequate filling status, as well as this, if there is end organ hypoperfusion like altered mental status, cold skin, oliguria, anuria, or increased lactate. So these are the features called obstructive shock. Similarly, persistent hypotension is said to be present when systolic BP less than 90 mmHg or systolic BP drop more than 40 mm, lasting longer than 15 minutes, and not caused by any other arrhythmia, hypovolemia, or sepsis. So presence of either of these three features indicates the hemodynamic instability of the patients. So whenever we suspect a pulmonary embolism patients with shock, so what we should do whenever we suspect, so is CT immediately available or not? We should try to do a CT scan. If it is available, do a CT scan. And if it is positive for pulmonary embolism, so this is specific treatment is justified. Consider thrombolysis and embolectomy in high-risk patient. And if the CT scan is negative, so look for the other causes of problems of the patient. And in case of if the CT scan is not available or the patient is very much serious, cannot be transported to the CT scan department, in that case, what to do? In that case, echocardiography plays a very important diagnostic role. Echocardiography can show us right ventricular overload or right ventricular dysfunction. If there is no right ventricular overload or dysfunction, again, there is no pulmonary embolism. So patients with shock having a normal right ventricular function, practically we can exclude the presence of pulmonary embolism, and we have to look for other causes for shock. But if the right ventricular dysfunction is found, in that cases, we can straightway give the antithrombolytic therapy or other cause. Even if the patient is not approached to the CT scans, with the help of shock and cardiovascular right ventricular dysfunction, so there is a possibility of giving thrombolytic therapy in these patients. And other group of the patient, that is patient of pulmonary embolism, but non-high risk pulmonary embolism, that is without shock. What to do? Again, we have to assess for the clinical probability as with the Wells or simplified Geneva scores. and to identify the patient whether it is low or intermediate clinical probability or pulmonary embolism unlikely, or high clinical probability or pulmonary embolism likely. When there is high probability, do an CT scan. If it is diagnostic of pulmonary embolism, send him treatment, give him treatment. If negative, so no treatment and investigate for other cause. And in the low probability or intermediate probability or pulmonary embolism unlikely category of the patient, it is indicated to do a D-dimer, not CT scan. Indicated to do a D-dimer. If D-dimer is negative, it excludes pulmonary embolism. If it is positive, then advise for CT scan. If CT scan positive, give treatment. If negative, again, it excludes the possibility of pulmonary embolism. So in case of shock patient or high-risk patient, we have to adopt the CT scan and take help of the echocardiography. In case of low probability, we have to do D-dimer and then CT. Now, if we have reached a diagnosis that the patient has pulmonary embolism, now how to treat these patients? So these are the treatment modalities: hemodynamic support, ventilatory support depending upon the seriousness of the patient, anticoagulation, thrombolysis, surgical embolectomy, percutaneous technique, and use of IVC filter. So in serious patients, the 10% patient who can present with hemodynamic instability, so we have to support the patient. Right ventricular support. Right ventricular failure is the main cause of mortality. We know it. So we have to give the support to the right ventricle as well as blood pressure with noradrenaline, dobutamine, and modest fluid challenge. Modest fluid challenge, because if fluid is given hydrated, then again it can cause right ventricular further worsening of the dysfunction. And similarly, if the patient needs ventilatory support, again, we should remember that the high PEEP can again give abnormality, results in further dysfunction of the right ventricles. So these are the groups here. So causes, fluid management, vasopressors and norepinephrine is indicated here. And in very serious cases, the help of the ECMO can be taken. Anticoagulation is the mainstay of the treatment. So anticoagulation is the first step. Whenever we diagnose or whenever we suspect pulmonary embolism, what is to be done? The first thing to do is to give and start dose of LMWH, low molecular weight heparin, because giving a patient low molecular weight heparin will not do so harm, even if the patient don't have pulmonary embolism. But if the patient is really suffering from pulmonary embolism, the first stat dose of low molecular heparin can change the scenario totally. So anticoagulation prevent the early death as well as prevent the recurrent VTE. So give anticoagulation as soon as possible. Initial parenteral anticoagulation for 7 to 10 days. Then vitamin K antagonist warfarin after the initial phase for up to 3-month duration is essential. Newer anticoagulants, NOACs, can be started earlier, like rivaroxaban or apixaban. The efficacy of the early heparin is attributed to what is the advantage? It can attribute it to the impairment of the clot propagation and prevention of the recurrence. So as quickly we can use the anticoagulation, there will be we can impede the clot propagation and also prevent the recurrence. So these are the two important advantages here. But the risk of recurrence, we know that the early stage of the disease process is the risk of recurrence, and during which time it is very crucial to rapidly achieve a therapeutic level of anticoagulations. So we have to achieve the therapeutic level, not only just to give an anticoagulants. So what are the choice? What are the available anticoagulants at our hand? Unfractionated heparin, low molecular weight heparin, and fondaparinux. Unfractionated heparin, we know, short duration of action, suitable for patients with renal impairment, obesity, heat possibility, and we need APTT monitoring during giving unfractionated heparin. In low molecular heparin, twice daily or single dose administration can be given. Causes should be taken for renal impairment in the patient. Again, heat possibility here, that is heparin-induced thrombocytopenia can happen, is unfractionated heparin, but less commonly in low molecular heparin. Anti-10A level monitoring if possible. Fondaparinix once daily subcutaneous injection, results comparable to that of unfractionated heparin, but not reported hit like the effect. It accumulates in the renal failure also. So it is avoidable in renal failure patients. So these are the low molecular heparin, most commonly used enoxaparin in the dose of this, dalteparin in this dose. So those should be properly adjusted according to the body weight of the patient to have a proper effect, anticoagulation effect. It can be given 12 hourly or once daily. Dalteparin again can be given 12 hourly, once daily. So weight adjusted dosing is very important for achieving an anticoagulation effect. Oral anticoagulant, warfarin, the vitamin K antagonist started as soon as possible, but we have to keep the INR in between 2 to 3. And new oral anticoagulant, dabigatran and rivaroxaban are used nowadays. NOAC are non-inferior to unfractionated heparin or warfarin. Possibly the bleeding risk is lesser. That is the advantage. Recommendation for rivaroxaban, apixaban, and indoxaban. So advantage of using NOAC are that the bleeding risk is less, and we don't have to regularly monitor the activity of the anticoagulation here. So it is the fixed dose, weight adjusted dose we can give it properly to the patient, and the patient can be relaxed here. Only thing needed is to proper adherence to the drug. Need not to monitor his. So the guideline says that when oral anticoagulation is started in a patient with pulmonary embolism who is eligible for NOAC, either apixaban, dabigatran, or rivaroxaban, a NOAC is recommended in preference to BKL. So it is always preferable in comparison to the warfarin. So these are the differentiating characteristic features of the warfarin and other NOACs here, dabigatran, rivaroxaban, and apixaban. So we know that the warfarin is vitamin K dependent inhibitor, and these are factor 10 inhibitors. One thing to note here that all of them has antidotes available in our country. Most likely, I don't know about this. Adnexeta alpha, rivaroxaban, as well as apixaban. So these are the antidote. We should be aware about the presence of the antidotes, and dabigatran, idarucizumab. So these are the antidotes available. And for warfarin, this is vitamin K, we know it. But one important factor to know that in case of a renal failure, warfarin can be given because it don't have a renal excretion. But dabigatran, rivaroxaban, and apixaban should be cautious about because they have renal excretion. So in renal failure patient, it is better to avoid NOAC. So in whom should not be used NOAC? So who are the patients where you don't use NOAC? Extensive DVT or massive pulmonary embolism, heparin is the drug of choice. And high initial risk of bleeding, again, heparin is better. Antiphospholipid syndrome, warfarin. Pregnancy, low molecular weight heparin, because warfarin and NOAC, they cross the placenta. Active cancer, again, low molecular heparin. And creatinine level, renal failure, less than 30 or 30 to 50, again, warfarin is the choice here. And it is better to avoid NOAC. Thrombolytic therapy. Thrombolytic therapy restores the pulmonary perfusion earlier than the anticoagulation therapy. And atiplage is the FDA approved. Nowadays, tenecteplase is also used as a thrombolytic therapy. 2 hours accelerated therapy is preferred over 12 to 24-hour prolonged infusion therapy. More than 90% patients have clinical recovery within 36 hours of therapy. The greatest benefit seen in therapy when the therapy is initiated within 48 hours of the presentation. So earlier the use of thrombolytic, better results can be achieved. But the negative point is that major risk of bleeding, intracranial and non-intracranial, up to the tune of 2%. So the greatest benefit is observed when treatment is initiated 48 hours of the symptom onset. But thrombolysis can still be useful in patients who have had symptoms for 6 to 14 days labs. So these are the thrombolytics used, RTPA, and this is the dose, 100 milligram over 2 hours and 6 milligram per kg over 15 minutes loading doses. Streptokinase, urokinase, it is RTPase gives a better result than this streptokinase and urokinase. Surgical embolectomy. It is done since 1924, indicated for failed thrombolytic therapy or where there is contraindication among immediate or high-risk patient. So surgical pulmonary embolectomy is recommended for patient with high-risk pulmonary embolism in whom thrombolysis is contraindicated or thrombolysis has failed. Percutaneous catheter-directed treatment is a very good modality of the treatment in the higher center for acute management of the pulmonary embolism. This percutaneous catheter-directed can be given, with the thrombolysis can be given through the catheter, or there are other modalities of treatment for the pulmonary embolus like thrombus fragmentation, rotational thrombectomy, suction thrombectomy, rheolytic thrombectomy techniques are very good techniques which can very good results. And systemic thrombolysis is contraindicated. Systemic thrombolysis is contraindicated in that patients we can opt for this. Randomized control trial shows that superior in reversing the right ventricular function within 48 hours as compared to the systemic thrombolysis without being bleeding complications. That is the most important thing. So if you have this option in your hand, so it is always better to give systemic instead of systemic thrombolysis, particularly high-risk patient. So percutaneous catheter-directed treatment should be considered for patients with high-risk pulmonary embolism in whom, again, thrombolysis is contraindicated or thrombolysis is failed. So both this surgical embolectomy and the catheter-directed treatments are particularly advisable in high-risk patients with shock and serious conditions and where thrombolysis is contraindicated or thrombolysis has failed. IVC filter. Infrarenal placement is usually done here in cases. IVC filter should be considered in patients with acute pulmonary embolism and absolute contraindication to anticoagulation. Should be considered in cases of pulmonary embolism with recurrence despite the therapeutic anticoagulations. So recurrence of pulmonary embolism on the backup of patient is getting thrombolytic therapy, anticoagulation therapy. Again, if there is a recurrence, so that is a situation where we can opt for these IVC filters. It is routine use of IVC filter is not recommended. Secondly, whenever we come across a patient with serious patient, again, pulmonary embolism severity index has to be estimated. Pulmonary embolism severity index, that is PACE index, shortly called PACE index. It estimates the risk of 30-day mortality from pulmonary embolism, and that gives an assessment of how aggressive we have to go or how to categorize the patient and how aggressively we have to manage this patient. And it includes demographic, comorbidities, and other clinical findings. But again, this is very tedious scoring system. So like this Wells score and the Geneva score, again, a simplified PACE has been advised and advocated. So when the patient's age is more than 80 years, or there is a history of cancer, history of cardiopulmonary disease, systolic BP less than 90, heart rate more than 110 beats, or oxygen saturation less than 90. So these are 8 parameters having 1 point each. And this is very simple. We can memorize it. And if the score is 0, the 30-day mortality risk is found to be 1%. But if the score is more than 1 or more than 1, then 30-day mortality is very high, up to 10.9%. So this gives a very good implication, very good assessment of the patient's seriousness and the 30-day mortality risk. 0, 1%, but more than 1, there is found to have very high risk of mortality, 10.9%. So another diagnostic test we must use is the NT-proBNP or BNP and the troponin test in all patients of having high risk the patient. Right ventricular pressure overload, in that cases, there is increasing myocardial stress that leads to increase in BNP and natriuretic peptide. And it has a very high negative predictive value, particularly, and hemodynamically stable patient with low or NT-proBNP level may be a candidate for early discharge and outpatient treatments. That is having very good negative predictive value. So markers of myocardial injury. So myocardial ischemia and necrosis of the right ventricle, there can be elevated trop I or trop T. So elevated plasma troponin concentration again gives a very good prognostic implications. So with the help of this hemodynamic assessment of the hemodynamic assessment as hemodynamic instability, particularly patients with hypotension, shock, and the PACE scoring, PACE 0 or PACE 1 or more, right ventricular dysfunction identified with echocardiography, and elevated cardiac troponin level. So these, with the help of these 4 indicators or 4 parameters, we can have an assessment of early mortality risk of these patients. And they are grouped in high mortality risk, low mortality risk, or intermediate mortality risk. So when the patient is having shock or hypotension and PACE score is 1 or more, there is right ventricular dysfunction in echo, and there is high trop I. So all these 4 parameters are positive. The patient is designated as high risk for the early mortality. And if all these are negative, the patients are at low risk of mortality, very low risk. And in between, if the patient have no shock, but having cardiac dysfunction, right ventricular dysfunction, and trop I positive, they are designated as intermediate high. And if one of these 2 or none are present, then they are called intermediate low risk. So in this way, we have to classify this patient having low risk of early mortality, high risk of mortality, and accordingly, we have to check out the treatment plan. So as you can see in this patient, high risk patient, first give an anticoagulation and then assess the hemodynamic instability. If the patient has hemodynamic instability as indicated by right ventricular dysfunction, these are designated as high risk, and then they have to give reperfusion treatment and hemodynamical support. And if the patient has no hemodynamic instability, that is no hypotension or shock, then again we have to go through the PACE scoring as well as to assess the right ventricular dysfunction. If the PACE is 1 or 2 is present, either PACE is 1 or more and the right ventricular dysfunction, both are present, then they are called intermediate risk of the patient. So troponin, then we have to do for trop I test. If trop I positive and right ventricular dysfunction is present, then it is called intermediate high risk groups, and they have to be admitted in hospital for monitoring. And if the patient deteriorate, then we have to give a rescue reperfusion if the patient deteriorate. But if trop I is negative, only PACE is positive or only right ventricular dysfunction is present, then this patient can be treated at hospitalized ward with proper monitoring. But if the patient has none of this, neither hypotension, or nor the PACE, right ventricular dysfunction or trop I, so these are the low risk patient. If no other reason for hospitalization and there is family and social support, the easy access to the medical care, they can be discharged for the treatment. So these are the algorithm for the assessment of the patient treatment here. Now this middle portion group, that's the intermediate category. So these are the main problem here. So high risk group, thrombolytic therapy or reperfusion therapy. Low risk groups, anticoagulation can be treated at home. So what should be done with this intermediate group? That is the questions. So studies have been done to give whether the patients with intermediate high risk, they get benefit from the thrombolytic therapy. And this was a study, PITHO study was done. This study showed that that there was improvement in the right ventricular function, but at the cost of high risk of bleeding. So that's why guideline says that rescue thrombolytic therapy is recommended for patients with hemodynamic deterioration on anticoagulation. That is, high-risk patient has to be treated with anticoagulation in hospital, and they have to be watched. If there is deterioration, then there is an indication for a rescue thrombolytic therapy. Routine use of primary systemic thrombolysis is not recommended in patients with intermediate or low-risk patients. There are certain special circumstances, particularly pregnancy. D-dimer and venous compression ultrasonography is done to avoid the irradiation risk. Perfusion scintigraphy, when the chest X-ray normal, so VQ scintigraphy is indicated in these cases. CT angiography only when the chest X-ray is abnormal. And anticoagulation, low molecular weight heparin adjusted to the weight is the treatment of choice in patients with shock in pregnancy with pulmonary embolism. In cancer patient, incidental pulmonary embolism on cancer screening is treated along with the same guideline, same line. Negative D-dimer has similar negative diagnostic value. LMW is adjusted to body weight and is used for 3 to 6 months. Extended anticoagulation with LMWG is considered until the cancer is cured. If there is transient thrombus, what to do? That we can see is a transient thrombus here. Studies have done, and it has been found that whether we use embolectomy or thrombolysis or heparin, mortality rates are almost the same. So we can use any of the mortalities in these cases. If the patient present with cardiac arrest, echo can be done during the arrest, and the only control trial shows thrombolysis during the CPR. CPR should be continued over a period of 1 hour, and ECMO can be helpful in this setting. Now, optimal duration of anticoagulation. So first provoked proximal DVT, 3 to 6 months. And first provoked upper extremity DVT, isolated DVT, again 3 months. Second provoked VTV for recommendation is for indefinite duration anticoagulation. Third VTE, consider indefinite duration. And first unprovoked cuff DVT, 3 months. Second unprovoked cuff DVT, uncertain durations. So duration again depend upon the risk of recurrence and the events of the recurrence of this patient. Chronic thromboembolic pulmonary embolism occurs in 1.5% of the patient diagnosed with earlier pulmonary embolism. So diagnostic criteria are finding after 3 months of the effective anticoagulation, if their mean pulmonary artery pressure is 25 mmHg or more, with pulmonary arterial wedge pressure less than 15, or at least one perfusion defect detected by perfusion scan or pulmonary artery obstruction seen in CT angiography. VQ scanning is the investigation choice for the diagnosis in these patients. Pulmonary endarterectomy are offered if operable, and if not, then extended anticoagulation is advised. So in summary, strong clinical suspicion is necessary to investigate and use the diagnostic strategy. Judicious use of investigation will avoid unnecessary burden in patient care delivery. Always check the pretest probability, and choice of therapy is very vital in indicating better patient outcome based on the mortality risk. So stepwise, as we discussed, we have to have a clinical suspicion. Then we assess the pretest probability, use the diagnostic modality to prove the pulmonary embolism. And when pulmonary embolism is proved, we have to do a severity or mortality risk stratification. And accordingly, we have to give definitive treatment. For high-risk patient, reperfusion treatment, a low-risk patient, and home treatment can be given with anticoagulant. And the dubious situation is particularly matter to be discussed or matter to be taken decision for intermediate group of the patients. So I end my talk here. Thank you very much.
So from ICP and from our side also, thank you very much for your comprehensive talk. And please take up a few questions from Neha or somebody.
Yes.
in-
Yes.
Short. Some in patient with intracranial hemorrhage, how to manage PE? This is one of the questions.
So any intracranial hemorrhage is an high risk patient and high risk of bleeding. So in this situation is massive embolism. If there is massive embolism, and arterectomy or catheter-based treatment can be attempted. So any form of anticoagulation, either oral or injectable, will be risky here, is not recommended.
And then there is anticoagulants only for massive PE or submassive or small PE.
Anticoagulation is for all PE. Any grade of PE, we have to start with anticoagulation first, and then stratifying the patient if they are high risk and large pulmonary embolus, not responding to the anticoagulation or other management. If the patient is in shock, then we have to think about thrombolysis. And if thrombolysis fails or not responding, and then the surgical measure has to be taken. This is the algorithm we have to think about in this way. So anticoagulation is for whenever we suspect pulmonary embolism, the first thing to do, given LMWH and continue for 6 to 7 days.
Is CTPA mandatory before thrombolysis?
No, it is not necessarily. If the patient is serious enough and cannot be transferred to the CT department, so here and bedside echocardiography with the assessment of the right ventricular dysfunction can give a clue for the further treatment. So if the patient is in shock and echocardiography shows enlarged right ventricle or bowing of the interventricular septum towards the left or TAPC less than 16 or the McConney signs. So these are the important signs, findings in the that indicate right ventricular dysfunction or right ventricular overload. And with the help of these features, we can go through further treatment.
The dyspnea always indicate large pulmonary embolism as RA, RB should be dilated or occluded pulmonary artery for dyspnea to appear.
Yes. So actually 30 to 50% of the pulmonary circulation has to be obstructed to increase the pulmonary artery pressure or pulmonary vascular resistance. In fact, so in case of small emboli, there will not be any increase in the pulmonary vascular resistance or pulmonary artery pressure. At least 50% or 30 to 50% of the pulmonary vascular bed has to be occluded. Then there will be increase in pulmonary vascular resistance, pulmonary arterial pressure that will result in pulmonary right atrial strain, dilatation, failure. And if we use the two diagnostic modality, one is echocardiography, bedside echocardiography, and bedside compressible ultrasonography of the deep veins. So if both these features, both these diagnostic modality give positive results, so that is an indication. Guideline says that there is no need for CT scan, particularly if the patient cannot be transferred, is serious enough, and that is the diagnostic modality which give a very positive predictive value and to go for the thrombolysis.
So thank you, Dr. Shyamala Sarkarji, for your comprehensive talk and almost answering all questions. Thank you very much. And
Thank you, sir.
We expect the short this write-up, 2,000 and 2,500 words with
Yes,
suggested reading.
Yes, sure.
Within a week or two.
Sure, sure.
Yeah, thank you, sir.
Yeah.
Thank you,
Thank you, sir.
very much. Good night.
Good night.
So your rather dinner will be overdue. Thank you.
No, no, no. Thank you.